So as I said, it's a great pleasure to be here with you. My name is Mark Evans. I'm a diabetologist here in the UK, based in Cardiff, where it is a Friday afternoon and the weather is very cold and dark and wet. And I'm sure in India it's far better. So for the next 40 minutes or so, I'm going to talk you through current concepts in micro and macrovascular complications of diabetes. These are my disclosures, and I've received honoraria and research grants from various pharmaceutical companies. So I think it's important just to stress that the opinions that I'll be giving during this course are not driven by any commercial imperatives whatsoever, but are my view on the way in which the data currently stands. So as a good place to start, it might be an idea to look back at an Abraham Lincoln comment in which he stated that he'd never allow a scientist to partake in government, as giving them a new piece of information, they're likely to change their minds. And I think in terms of understanding how we treat diabetes currently, this is a very pertinent comment. We have a lot of data, a lot of evidence that's really influencing guidelines, clinical practice, and our understanding of how best to develop treatment strategies for managing patients with diabetes. So if we start off and look at life expectancy in people with type 2 diabetes, undoubtedly cardiovascular disease is the main cause of morbidity and mortality. If you're 60 years of age, diagnosed with type 2 diabetes, in the presence of coexisting cardiovascular disease, you lose around 12 years of your life expectancy. Without cardiovascular disease at the age of 60 at diagnosis, that loss of life expectancy is around 6 years. So all of that driven by adverse cardiovascular outcomes. So improving cardiovascular risk is central to the management of type 2 diabetes. However, it's worthwhile remembering that all of the epidemiology data illustrates, in fact, that clinical outcomes are improving. This is some Swedish epidemiology data, and this is true all over the world, including India, the US, and of course here in the UK. With a 50% reduction in all-cause diabetes-related mortality in people diagnosed in the mid-1990s compared to those diagnosed in the mid-1970s. And this is driven by many factors, particularly improved treatment and management of the complications. What we do know is that better glucose control is actually an important factor in reducing the burden of diabetes-related complications, and many studies have demonstrated this. The seminal one is the UK PDS trial, illustrating that for a 1% reduction in HbA1c, there were reductions in both micro and macrovascular complications. And it's worthwhile bearing in mind that vasculopathy, as we shall discuss, is both micro and macrovascular in terms of type 2 diabetes. And understanding the vascular burden of the condition is central to understanding the cost associated with type 2 diabetes. And we know by long-term modeling disease outcomes that better glucose control translates into a reduction in lifetime treatment costs, but also a reduction in complication burden. If we look at two patients with an HbA1c of 9 versus an HbA1c of 7 over a lifetime, the person with good glucose control will live longer, have less in the way of complications, and will cost less. And the reason for this is that complications, as illustrated in this slide, drive the bulk of the costs of the condition. 80% of diabetes treatment and management costs are driven by complication cost management. Around 11% of any healthcare budget globally is consumed by diabetes, the vast majority of which being driven by complication costs. When we look at the breakdown of value savings related to better metabolic control, clearly as illustrated in this slide, investment in better glucose control only accounts for around 8% of the lifetime expenditure on somebody with diabetes. By far, the greater saving is in those where there is driven by reduction in complication costs. Now, From the perspective of costs of the condition, nephropathy is by far the most expensive, particularly end-stage renal disease. And diabetes is responsible for around 30 to 40% of all cases globally of end-stage renal disease. Nephropathy affects about 40% of people with type 1 diabetes and 30% of people with type 2 diabetes. The manifestation of nephropathy being either microalbuminuria, macroalbuminuria, or progressive decline in renal function. The pathophysiology of diabetic nephropathy is linked to hyperglycemia and its effect on glomerular basement membrane physiology. Blood pressure is also an important factor, as is an inflammatory diathesis, resulting again in glomerular basement membrane injury. The initial manifestation of nephropathy in diabetes, as we know, is with albuminuria, which progresses to declining glomerular filtration and ultimately end-stage renal disease. Retinopathy is another microvascular complication that can be very expensive and is influenced by better metabolic control. Diabetic retinopathy in the UK was the leading cause of blindness in people of working age. However, the incidence of sight loss has now reduced largely due to the success of the National Retinal Screening Programme that we have established here in the UK. So if we again go back to this discussion on retinopathy, as I said, the pathophysiology of this is linked to retinal ischemia and microvascular dysfunction, similar to that we see with diabetic nephropathy. And as such, retinopathy incidence is closely linked to both glucose control and the presence of diabetic kidney disease. Interestingly, we are just preparing a manuscript looking at the association of retinopathy with other microvascular complications. And in particular, autonomic neuropathy is very closely linked to the development of diabetic retinopathy, such that 90%, interestingly, of people with proliferative retinopathy will have some evidence of diabetic autonomic neuropathy and cardiac autonomic neuropathy in particular. If we go on to talk about neuropathy, 50% of people with diabetes will exhibit some form of neuropathy at some point during the course of their condition. Many forms of neuropathy exist. The most common is usually sensory or motor, but this neuropathy can, as we know, present as either mononeuritis or as a multiple neuropathy. So I don't know what's going on here. So the classification and identification is based on clinical presentation, and the neuropathic symptoms can indeed be very debilitating and difficult to treat. Similar to other microvasculopathies, pathophysiology is linked to microvascular dysfunction, and in this case resulting in nerve sheath ischemia. Risk factors include poor glucose control, smoking, diabetes duration, and of course the presence of other complications. As I said, in particular retinopathy is a very important risk factor and comorbidity for the presence of neuropathy. Autonomic neuropathy is actually very frequently unrecognized in people with diabetes and can present in a variety of ways. The typical presentation that we're all aware of is post-gustatory sweating, but also postural hypotension, difficult to treat diarrhea, gastroparesis, and sudden cardiac death are also manifestations potentially of diabetic neuropathy. Finishing off on the microvascular discussions, before we move on more formally to think about macrovasculopathy, diabetic foot disease is a very important comorbidity and accounts for about 135 lower limb amputations globally per week. The main manifestation is in non-healing ulceration. Multiple risk factors exist for diabetic foot disease, in particular poor glucose control, smoking, long duration of diabetes. And in essence, diabetes incurs about a 25% lifetime risk for the development of foot ulceration. Approaches to reduce the risk of such problems include, in particular, education around foot care, as well as multiple risk factor intervention. Now, if we talk about multiple risk factor intervention, one of the seminal studies that illustrated the importance of this was the STENO 2 study. And in this study, we had patients with type 2 diabetes, only 160, with an increased risk of cardiovascular disease, defined as the presence of microalbuminuria, randomized to either intensive therapy in terms of glucose, lipids, and blood pressure control versus conventional therapy. And what this study demonstrated over an 8-year time frame was that the achievement of glucose, cholesterol, triglyceride, blood pressure, and diastolic blood pressure control was associated with significant outcome benefits in terms of both micro and macrovascular outcomes. Furthermore, when we explore these data, we can see that the benefit occurred almost within 12 to 24 months of randomization, therefore illustrating that intensification of multiple risk factor intervention is rewarded by outcome benefits very early on within the exposure to a better risk factor control. So when we look at vascular protective approaches, I'm just going to very quickly review some of the evidence that we have for statins, ACE inhibitors, and aspirin use. The HPS study clearly illustrated in the context of secondary prevention that statin use was associated with cardiovascular disease outcome benefits. Indeed, in those people with no prior history of coronary heart disease, including patients with diabetes, there was still benefit in terms of outcome benefits with statin therapy. The CARS study looked at statins for primary prevention in people with diabetes, 2,800 or so patients aged 40 to 75 with type 2 diabetes with additional cardiovascular risk, including, as we see here, retinopathy, albuminuria, hypertension, or smoking. Intervention here being low-dose statin versus placebo, with the outcome being a composite of ACS, revascularization, or stroke. And in this study, as in any other statin study, we saw a significant benefit with respect to cardiovascular outcome, both primary and secondary outcomes in those patients treated with atorvastatin. The HOPE, and in particular the MicroHOPE study, illustrated for the first time the benefit in terms of CV outcomes of ACE inhibitor versus non-ACE inhibitor based treatment, with very favorable NNTs here for a primary outcome of only 22, all-cause mortality with an NNT of 31, with MI, stroke, and CV death having an NNT of 37, 53, and 29, respectively, over around a 4-year follow-up period. The question has always been, is there a difference between ACE and ARB? My view, based on the evidence, and this is the on-target trial using an ARB versus an ACE inhibitor for cardiovascular disease protection, and this is telmisartan versus ramipril, that appear to be no difference. Therefore, an ARB or an ACE inhibitor would appear, to my mind at least, to be interchangeable in terms of cardiovascular protection. With respect to aspirin therapy in type 2 diabetes, aspirin for primary prevention of cardiovascular events in the condition was evaluated by this meta-analysis of trials with over 10,000 participants. And basically, in this meta-analysis of 6 studies, there did not really appear to be any evidence of benefit for primary prevention in statin therapy in people with type 2 diabetes. Of course, those with higher cardiovascular risk or established cardiovascular disease, the story may be different. However, if we now go back to evaluate the more contentious issue of glucose control, we know that, and this is data from the UK-PDS, that intensification of glucose control is associated with potential outcome benefits. And from an epidemiological perspective, increasing HbA1c is, as we see here, associated with an increase in the risk of fatal and non-fatal MI, non-fatal and fatal stroke, amputation and death from PVD, as well as heart failure. However, meta-analysis of intensive glucose control trials in type 2 diabetes, as illustrated by the Turnbull meta-analysis presented here, has really failed to demonstrate any particular benefit in terms of all-cause mortality or cardiovascular outcomes for intensification of glucose control. And this has been the focus of a lot of interest in terms of the cardiovascular outcome trials. And the cardiovascular outcome trials are, in essence, cardiovascular safety studies evaluating the effect of new glucose-lowering therapies compared to older glucose-lowering therapies with respect to cardiovascular outcomes, and the cardiovascular endpoints, as driven by a regulatory perspective, are cardiovascular death, non-fatal MI, and non-fatal stroke, with additional secondary endpoints such as heart failure or unstable angina included. Now, I'm going to run through some of the already presented cardiovascular outcome trials to give us some idea of where we are with the data, and I'm sure you've seen many of these already. But in essence, these trials include very high-risk cardiovascular patients, with the Examine study, for example, including patients with recent acute coronary syndrome. All of these studies, bar the Canvas program, had over 75% or so patients with established cardiovascular disease, with the objective here being to assess the impact of the diabetes therapy in question, be that a GLP-1 receptor agonist, be that an SGLT2 inhibitor, or a DPP-4 inhibitor, with respect to cardiovascular outcomes in the context of risk factor equipoise, such that all risk factors between the two arms, standard of care and investigational arms, were supposedly the same. In terms of the CVOT designs, it's probably worthwhile just reminding ourselves that these studies are quite different actually in terms of design. They're all generally event-driven, apart from the LEADER trial that had a minimum exposure requirement of 3.5 years. The duration of exposure is relatively short, with the EMPA-REG and LEADER trials really being the only studies with duration of exposure of over 3 years. In terms of baseline characteristics, again, these trials are fairly similar, but there are differences that make indirect meta-analysis type comparisons impossible. Baseline age is around mid-60s, but duration of diabetes ranges from anything from 7 up to 16 years in the DEVOTE and nearly 14 years in the SUSTAIN-6 study. BMI is in the region of 30, and baseline HbA1c is anything from just over 7% to nearly 9%. In terms of the results, it's just worth reminding ourselves that the results of SAVOR, Examine, TCOS, and the Alexa trials demonstrated really no difference in terms of CV outcomes in association with saxagliptin, alogliptin, sitagliptin, or lixisenatide-based therapy versus standard of care. The SAVOR, TIMI, and Examine trials suggested an excess of hospitalization for heart failure. Post-hoc analysis, particularly of the Examine study, has really failed to demonstrate an association with increasing BNP levels, and the mechanism behind this still remains something of a point of debate, but I'm sure we could come back to that during the question and answer session. The once-weekly exenatide study, the Excel results are shown here. Despite the fact that there was a modest HbA1c difference in favor of the exenatide arm in this study, the point estimate for the composite endpoint was 0.91, with an upper boundary of 1 therefore statistically no evidence of any benefit in terms of cardiovascular outcomes defined by CV death, non-fatal MI, non-fatal stroke. The SUSTAIN 6 study was semaglutide versus standard of care, and in this there was a 26% reduction in non-fatal stroke in favor of semaglutide, and this could be driven by the fact that there was significant body weight, blood pressure, and HbA1c differences in favor of the semaglutide-treated patients. The other two CVOTs that have stimulated a lot of interest is the EMPA-REG and the LEADER trials, and these are the study designs shown here. And in terms of the primary outcome, both EMPA-REG and LEADER demonstrated outcome benefits in favor of either empagliflozin in the EMPA-REG trial or liraglutide in the LEADER study. Breaking these individual components down, it was a 38% reduction in CV death in the EMPA arm of the EMPA-REG trial, with a 22% reduction in CV death in the liraglutide arm of the LEADER study. From the perspective of other endpoints, non-fatal stroke was of a borderline numerical significance in the EMPA-REG trial, whereas in the LEADER trial it was really CV death that drove the outcome benefit. From the heart failure perspective, there was a significant reduction in heart failure hospitalization with empagliflozin in the EMPA-REG trial, with only a borderline statistically non-significant reduction in heart failure outcomes with the LEADER arm, or with the liraglutide arm of the LEADER study rather. The other interesting observation in the EMPA-REG trial in particular was a stabilization of GFR, and this is shown very nicely in this particular slide. And this profile looks very similar to that seen with a RAS inhibitor, an ACE or an ARP, and may speak to the mechanism of action of an SGLT2 inhibitor at the kidney level by reducing sodium and glucose reabsorption. There is a reduction in periglomerular basement membrane renin-angiotensin system activation, which may serve as part of the CV protective mechanism, and we could come back to potentially discuss that a little bit later on. But in terms of a composite endpoint of new or worsening nephropathy, there was a 39% reduction in favor of empagliflozin, and this was largely driven by a reduction in albuminuria, and in particular new onset macroalbuminuria. In addition, there was a 44% reduction in doubling of serum creatinine in favor of the empagliflozin treated subjects, with a 55% reduction in the need for initiation of continuous renal replacement therapy. In the LEADER trial, there was also a microvascular outcome benefit in terms of a composite of macroalbuminuria, doubling of serum creatinine, end-stage renal disease or renal death. And this was largely driven by time to first onset of microalbuminuria. And when you look at the microvascular events, this is clearly illustrated here, that the main determinant of microvascular outcome benefit in the LEADER trial was the development of a reduction in the development of albuminuria. The other trial I think that's worthwhile just discussing very briefly is the CANVA study. And in this study, this is canagliflozin versus usual care, modest HbA1c, body weight and blood pressure differences. But what we did see was an outcome benefit in terms of the composite of CV death, non-fatal MI, non-fatal stroke, with a 14% reduction in favor of canagliflozin, but no significant impact noticed on cardiovascular death, which is a differentiator to the EMPA-REG trial. Some of the important comparisons have been made, and as I mentioned, CV death is quite different in the EMPA-REG compared to the CANA canagliflozin study of CANVAS. But otherwise, the outcomes are fairly similar, particularly when it comes to heart failure. One of the areas where there has been a difference, however, is in terms of adverse event safety within this particular study. And if we look at that, there's the next slide. The adverse events were something that were quite noticeably different. In the CANVAS trial, not surprisingly, there were more mycotic infections in the canagliflozin treated subjects, both males and females. Ketoacidosis was numerically higher, but not statistically significant, with only a few events seen. However, what was noticed in this particular study was an excess of lower limb amputations, and that excessive lower limb amputation, when a multivariate analysis is applied to the data, there were excessive amputations was similar in the canagliflozin exposure rather, was the same as having, for example, peripheral vascular disease, poor glucose control, prior neuropathy, in terms of determining the increased risk of lower limb amputation, independent of other factors. In addition, fractures were increased in the canagliflozin arm of the CANVAS program, and this tended to cluster in the CANVAS rather than the CANVAS-R arm. CANVAS-R was a shorter component study of the CANVAS program, and this may be a duration of exposure effect. From the EMPA-REG perspective, meta-analysis of the initial clinical trials, the registrational studies, have demonstrated no increase in lower limb amputations with empagliflozin, while post-hoc analysis of the EMPA-REG outcome study also did not demonstrate any significant increase in lower limb amputation with empagliflozin. Risk of bone fractures across the empagliflozin clinical trial program, as well as the EMPA-REG study, has also failed to actually demonstrate an excess of fractures in association with EMPA compared to standard of care or placebo. From a pharmacological perspective, there is some discussion as to why this might actually be the case. And what we see is that pharmacologically, the three SGLT2 inhibitors are actually a little bit different in that empagliflozin has actually very high selectivity for SGLT2 inhibition, much higher than, for example, DAPA, and much higher than CANA, where canagliflozin also has an element of SGLT1 inhibition. The relevance of this in terms of driving the risk of side effects is not entirely clear at the moment. In addition, there is a difference between empagliflozin and canagliflozin in terms of the degree of glycosuria, with empagliflozin inducing around 80 grams of glycosuria per day compared to up to 120 seen with canagliflozin. The relevance again of this in terms of the complications is something that is up for debate. From the viewpoint of SGLT2 versus SGLT1 selectivity, here's some interesting data that really shows us that SGLT2 is primarily expressed only in the kidney, whereas there is SGLT1 receptor expression on other tissues, and the relevance of this in terms of driving, as I've already mentioned, the excess adverse event profile seen in the CANVAS program is something that is worthwhile discussing. So just to finish, based on all of these studies, there have been very many changes to both guidelines, to both product labels, all of which now would suggest that in people with established or at very high risk of, or with established cardiovascular disease, evidence-based medicine such as empagliflozin or liraglutide should form the cornerstone of our treatment approaches for managing glucose control in these patients. And this has been supported by both label updates in the US as well as here in Europe along with guideline updates across the world. So to summarize, ladies and gentlemen, what we know is that diabetes is a significant clinical and economic burden based on an excess of vascular complications, both micro and macrovascular. Multiple risk factor intervention from a therapeutic perspective is the cornerstone of reducing complication burden, and there is growing evidence to support the benefits of specific therapies with respect to vascular outcomes, in particular empagliflozin, in particular liraglutide, but also potentially semaglutide, as illustrated by the SUSTAIN-6 study. So thank you very much for your attention to this brief overview of what is a very complex field. And I'm now going to spend the next maybe 30 minutes or so dealing with and answering, or attempting to answer at least, some of your questions. So thank you very much indeed. So please post your questions. So I've got the first question here I have is, what should be the safe range of HbA1c for cardiac safety in diabetes? Well, I think the optimum HbA1c that we should be really looking for is an HbA1c that's as low as we can achieve without inducing excess hypoglycemia risk. I think there's undoubted evidence that there's an association between hypoglycemia and adverse clinical outcomes, and I think achieving an HbA1c that is as good as we can without inducing an excess risk of hypoglycemia is actually very important. Another question here is, how common is neuropathy during the onset of diabetes? Up to 20 to 25% of people who present with type 2 diabetes will have some element of neuropathic symptoms. And this is largely due to the delay in diagnosis that we have for type 2 diabetes. It's also important to remember that in people who have retinopathy, nearly all will have some form of neuropathic symptoms. As I said, in particular, autonomic and cardiac autonomic neuropathy. Should aspirin be prescribed to every diabetic person, irrespective of their cardiovascular risk? I think the data for this would suggest no. There is no evidence of primary prevention benefit with aspirin, particularly in those at low cardiovascular risk. In those subjects with an elevated cardiovascular risk or those with established cardiovascular disease, I think that there is benefit for the use of statin therapy, of aspirin therapy in these individuals. The definition of high cardiovascular risk for me would be the presence of type 2 diabetes plus at least one other cardiovascular risk factor, in particular albuminuria, would make me think of prescribing aspirin. My next question here is, what should be the cutoff criteria for implementation of empagliflozin with respect to EGFR? It's a very interesting question. Currently, the cutoff for initiating an SGLT2 inhibitor such as empagliflozin is 60, with the therapy being continued down to a GFR of 45. And that is purely based on glucose-lowering efficacy. In the registrational program, the difference between EMPA and placebo was less than 0.5% in those subjects with a GFR of less than 45. Now, there are ongoing studies in patients with GFR of 30 to 45, and even in those with GFRs lower than 30, the EMPRESS program, for example. And this will answer the question of whether or not the CV outcome benefits are seen independent of GFR. And there are only a few patients in the EMPA-REG trial that had GFRs below the 45 threshold. So that is something that is ongoing. So where we are at the moment, 45 is the threshold within the label, and 60 is the label indication threshold for therapy initiation. Which is the best medicine to treat diabetic neuropathy? Well, there is a nice guideline that I could refer you to for the management of diabetic neuropathy. In terms of symptomatic peripheral neuropathy, if there is presence of depressive symptoms, then duloxetine is very good. In the absence of that, then pregabalin is a very useful way of treating the symptoms. But the initial symptom management of neuropathic pain would be simple analgesia. So that would be paracetamol. It could include cocodamol, codidromol, etc. Inhibitors preferred. I think the question here is, are SGLT2 inhibitors preferable to DPP4 inhibitors? I think the answer to that question is very difficult. SGLT2 inhibitors certainly have benefits that have been demonstrated in the EMPA-REG trial and also the Canvas study, and also in the observational real-world study of that was published very recently in Circulation, the CVD real data. However, there are many patients who will not necessarily gain benefit or would be inappropriate to receive an SGLT2 inhibitor. And these, for example, might be the elderly, those with, at this moment in time, GFRs below 45, or those without, or those with established renal failure, for example, where we don't know whether an SGLT2 inhibitor will provide us with cardiovascular outcome benefit. So I think it's very much individualized, and there are many people who will still gain benefit from DPP4 inhibitor therapy. Treatment of xerostomia in diabetes. Well, I think the treatment of xerostomia would be oral care, improvement of glucose control, and stopping smoking. But in particular, improving glucose control can actually be very useful from this perspective. And there are many oral complications of diabetes that exist that are closely related to poor glucose control. Can microvascular complications be avoided with good glycemic control? The risk of microvascular complications can certainly be significantly reduced with improvement in metabolic control. And central to the management and reduction in complication risk is the management of glycemia. But reducing the burden of complications involves blood pressure, involves lipid control, body weight control, as well as glucose control, smoking cessation. And in terms of good glycemic management, we're increasingly aware, as I try to demonstrate, that there may be a qualitative as well as quantitative approach. Different drugs and different therapeutic regimens potentially providing better outcomes. We've seen that potentially with the EMPA-REG trial and also with the LEADER study. So we are moving to an era where not only how low is your glucose, but how do you get your glucose under control, being important with respect to defining outcomes. The last question that I have at the moment is, for microalbuminuria, should we use an ACE or an ARB? I think from my perspective, I don't think it matters. I think an ACE inhibitor or an ARB, based on studies such as the On Target, for example, are equivalent with respect to outcome benefit in my mind. So that is all of the questions that I currently have. Are there any other questions that anybody wishes to post? Are there any other questions from the audience? No, there we are. I've got some more now. Okay. So one of the questions here, which type of patients should avoid canagliflozin? I think this is a very interesting question. I think currently, if we are thinking that patients have a very high risk of lower limb amputation, then until we get a clearer understanding of what seems to be driving this differentiator, then I would be tending to sway towards empagliflozin in such individuals. Because data, for example, from the EMPA-REG trial has failed to demonstrate an excess of lower limb amputations in association with empagliflozin therapy. Is there any advantage of combining an ACE and an ARB in nephropathy? I think the answer to this is no. This can be associated actually with hyperkalemia, so is probably best avoided. Is it right to prescribe statins irrespective of lipid profile? Well, I think the data here would suggest, certainly from an epidemiological perspective, that there is continuing benefit down to LDL cholesterols of well below 2 millimoles per litre. And I think irrespective of lipid profile, a 1% reduction in HbA1c, a 1 millimole per litre reduction in LDL or total cholesterol has been shown to be associated with around a 24% relative risk reduction. Clearly, the lower the cholesterol, the higher the absolute risk, the lower the absolute risk. So in terms of your return on investment with respect to risk reduction, there will be less of a absolute benefit the lower the cholesterol. But in terms of relative risk reduction, there is still benefit with respect to reducing cholesterol independent of baseline level. Is there any role for vitamin D in patients with diabetic neuropathy? I'm not convinced currently that there is any evidence of vitamin D replacement in terms of randomized trials with respect to neuropathic outcomes. Vitamin B12 replacement may be of some benefit. As you know, metformin is determined of reduced vitamin B12 absorption. B12 can be reduced and contribute potentially to the neuropathy. In which type of diabetes is nephropathy most severe? Well, I don't think there's either type of type 2 of diabetes that makes nephropathy more severe. The greatest burden in terms of numbers is type 2 diabetes, simply because there are so many people with type 2 diabetes out there at the moment. And nephropathy is really related to hyperglycemia, duration of diabetes, but also blood pressure. And these factors are important both in type 1 and type 2 diabetes in terms of nephropathy progression. In terms of statins and diabetic nephropathy, no real evidence that statins prevent nephropathy. However, nephropathy is a marker of increased cardiovascular risk, particularly the presence of albuminuria. And if you have patients with albuminuria, there is no doubt that these individuals should be on a statin irrespective of their cholesterol levels. What percent of patients developing microcomplications despite a very good control in the long term? This is a very good question, in that there are people who will develop long-term complications irrespective of optimal glucose control. Clearly, optimizing glucose control will reduce the proportion or numbers of patients, But there are some people, irrespective of how good the glucose control has been, that will develop long-term complications. And this, of course, is driven by the fact that you can never be euglycemic if you have diabetes. But also illustrates the fact that it's not just glucose control we need to be thinking about. It's got to be multiple risk factor intervention, blood pressure, cholesterol, body weight, are all important determinants of complications. How safe is SGLT2 inhibitors in diabetic gastropathy? Well, there's no evidence that an SGLT2 inhibitor in gastroparesis will have any detrimental effect per se. I think a GLP-1 receptor agonist is probably best avoided if you have or are concerned that a patient has diabetic enteropathy or gastropathy. Should statin be prescribed to every patient with diabetes? I think that I think statins are very cheap. They're generally very well tolerated, and I think reducing cholesterol, irrespective of baseline cholesterol levels, is a very good idea. And my approach is, I think that everybody with diabetes should be treated to a total cholesterol of less than 4 millimoles per litre and an LDL cholesterol of less than 2 millimoles per litre. What would be the optimal dose of statin for primary prevention of coronary artery disease in diabetes, and what year age should it be started? That's a very good question. So I think here that the target cholesterol we should be thinking about, and as I mentioned in response to the earlier question, the target cholesterol here ought to be aimed for less than 2 millimoles per litre in terms of LDL cholesterol. From the age perspective, I think if you're over 40, it's very reasonable to be starting a statin. If you're a woman of childbearing age, it's best to avoid a statin until these ladies have finished having families. Statins are not recommended in pregnancy. And if you have women who have type 2 diabetes and are treated with a statin, then it is worthwhile ensuring that they are taking appropriate precautions in terms of avoiding pregnancy. Role of statins in diabetic nephropathy, I think we've already covered that. No evidence of nephropathy benefit, but clearly increased cardiovascular risk in patients with nephropathy. Do ACE inhibitors have an advantage over ARBs in terms of renal protection? I don't think that they do. In fact, the IDNT study demonstrated the nephroprotective effect of an ARB in terms of albuminuria, as well as preventing decline of GFR. Safe OHA in diabetes with liver failure. It's an interesting question. I think if you have established hepatic failure, then really the approach here would be insulin or metformin. But generally, my approach from the perspective of treating diabetes in people with fulminant liver failure would be to use exogenous insulin. Bear in mind, all OADs are licensed for use up to a baseline serum transaminase level of 2.5 times the baseline. What is the limit of GFR below which an OHA should not be prescribed? Metformin, we continue down to a GFR of 30. DPP-4 inhibitor, we can continue across the entire spectrum of GFR. Vildagliptin, there is a reduction in dosing frequency with a GFR below 50. Linagliptin, you can continue with the same dose, although there's no efficacy advantage. Sitagliptin, alogliptin, and saxagliptin have dose reductions based on GFR. Currently, you can continue with liraglutide and dulaglutide as GLP-1 receptor agonists down to a GFR of 30. And the current position with an SGLT2 inhibitor is down to a GFR of 45. Insulin, of course, you can also use across the spectrum of baseline GFR. Which oral hypoglycemic drug is better in kidney failure patients other than SGLT2 inhibitor and liraglutide? Well, no other drugs have actually been have demonstrated any nephroprotective effects other than the SGLT2 inhibitor or liraglutide in terms of the cardiovascular study data that we have to date. That being said, in terms of safety in renal failure, all of the DPP-4 inhibitors have been shown to have a safe glucose lowering effect in patients with established renal failure. Sulfonylureas may also be used, but clearly the issue here is a significant increase in the risk of hypoglycemia with these agents in renal failure. Should we check HbA1c every 6 months or 3 months? I think this is dependent on a variety of factors. First of all is affordability, secondly is practicality, and thirdly is whether or not that HbA1c has been stable. If you have patients with very stable, good glucose control, then I don't see checking it more than 6 monthly provides any benefit. If there's been a therapy intervention or HbA1c is deteriorating, then every 3 to 4 months would be entirely appropriate. Less than 3 monthly is not appropriate because of the glycation rate and half-life of hemoglobin A1c. How do you prevent autonomic neuropathy related cardiac arrest? I think that's a very good question. It's very difficult to do that, but in particular reducing glucose variability and frequency of hypoglycemia is important in this perspective. Is there any role for vitamin D in patients with diabetic neuropathy? Again, not to any definitive evidence for vitamin D improving neuropathic symptoms in a randomized trial setting that would be sufficient to include vitamin D within the neuropathic management pathway. How do we see vildagliptin? How do we see linagliptin? Well, linagliptin is a DPP-4 inhibitor that basically the advantage of which is that you can use it without having to change the dose irrespective of renal function. Other than that, currently I don't see any advantage whatsoever for linagliptin compared to any of the other DPP-4 inhibitors, and we are awaiting both the Carolina and Carmelina studies that will be looking at the cardiovascular profile of linagliptin. How do you treat cardiac autonomic neuropathy? Well, this is a very difficult condition to manage simply because many patients won't know that they'll have it. But avoidance of hypoglycemia, as I mentioned earlier, is actually quite important because this can exacerbate cardiac conductive dysfunction and therefore be a precipitating factor to sudden cardiac death. Which ARB is better for microalbuminuria? I don't think there's really any evidence for one ARB being better than any of the other. I did some of the work on the irbesartan IDNT study, so I tend to use irbesartan. If LDL is controlled with statins, do we need to focus on triglyceride? Well, the answer to this is that we don't really know. Triglyceride will be elevated if the glucose control is poor. Data from the Accord lipid sub-study suggested that a combination of a fibrate in terms of raising HDL and lowering triglyceride tended to be really a benefit in men with low HDL cholesterol and elevated triglycerides. So focusing on triglyceride per se has not really been demonstrated to go beyond that, and that was demonstrated in the lipid sub-study. However, fibrates may well be of benefit in terms of influencing the progression of retinopathy, and that is something that has been discussed, and there is often a role for fibrates in medical management of retinopathy. The dose of pioglitazone that is safe, well, in India, as you will know better than I, of course, and certainly in our South Asian patients here, small doses of pioglitazone can be very effective, as low as 7.5 milligrams a day. Tend to avoid the higher dose of 45 milligrams, largely because this is the dose associated with the greatest fluid retention and weight gain. So my therapeutic dosing of pioglitazone is from 7.5 up to 30 milligrams a day. Is there any contraindication of using pioglitazone in an SGLT2 inhibitor? No, there isn't really a contraindication per se. CV protection with SGLT2 inhibitor, is it a class effect or only found with empagliflozin? Well, I think the data at the moment, certainly from the perspective of CV death reduction, is only seen with empagliflozin. We have no data for dapagliflozin, and the CV death data for CANA in the CANVAS program demonstrated no benefit. So at the moment, we only have the empagliflozin data to go on in terms of CV death reduction with an SGLT2 inhibitor. How safe is an SGLT2 in gastropathy? I don't think there's currently any evidence to suggest that these drugs cause a problem in gastroparesis. How frequent is the incidence of UTI? UTI is fairly low. The main urogenital side effect with SGLT2 inhibitors is that of the urogenital mycosis or fungal infections, and these can occur at a frequency of up to about 10%. Now, the mycotic infections are usually self-limiting and will occur early on when it comes to treatment exposure, and are driven by degree of glycosuria. The higher the glucose when you initiate an SGLT2 inhibitor, the greater the degree of glycosuria and the greater the potential for mycotic infection. The way to manage this mycotic infection risk would be encourage oral fluid intake and regular personal hygiene. Which covered that one. Should telmisartan be preferred to olmesartan? I don't think that there's any data to suggest that that is the case. Can pioglitazone and SGLT2 inhibitor be prescribed in a patient keeping in mind fracture risk? Well, as I said, the empagliflozin data didn't demonstrate an increase in bone fracture risk, whereas canagliflozin did. So from that perspective, I think I wouldn't myself use pioglitazone with canagliflozin, but I certainly think there's no data around pio and empagliflozin. Role of gabapentin in diabetic neuropathy. Diabetic neuropathy is gabapentin along with pregabalin are agents that you can use for symptom management in diabetic neuropathy. So our approach here would be usually to use gabapentin up to a dose of about 1.8 grams per day. And that's often in combination with duloxetine, particularly if there is an element of depression. What is the safe dose of pioglitazone? Well, I think 15 to 30 milligrams would be my approach. Topical gabapentin for neuropathy, we tend not to use that very much. Don't think it's that effective. It's systemic gabapentin is our approach. What creatinine level is safe for prescribing an ARB? I think you can prescribe an ARB pretty much all the way down to GFRs of 30 or below. But I think the key point with an ARB or an ACE inhibitor in this situation is to monitor what happens to the potassium level. In patients with CKD, the use of an ACE inhibitor or an ARB will increase the potential for hyperkalemia. Are there any evidence of combining SGLT2 inhibitor and DPP4 inhibitor? Well, basically, combination of an SGLT2 inhibitor and a DPP4 inhibitor is an approach to managing glucose control, but you've got to bear in mind that part of the mechanism of glucose lowering of a DPP4 inhibitor is through glucagon reduction, and an SGLT2 inhibitor will increase glucagon levels. So fixed dose combination of an SGLT2 and a DPP4 inhibitor tend to produce less glucose lowering than you'd imagine that each individual component put together should do. But I don't think there's any issues with respect to combining an SGLT2 and a DPP4 inhibitor therapeutically. Is amputation a class effect of SGLT2 inhibitor or only CANA? So in terms of class effect, there is no evidence of an excess amputation risk so far with empagliflozin in any of the clinical trial data. We are waiting further analyses in terms of database studies, pharmacovigilance, etc., to look at this. And the regulators have actually mandated further safety evaluation of all of the SGLT2 inhibitor ongoing studies from this perspective. So the answer to this is that currently it does only appear to be CANA. I don't know whether that will be the case or not. I think we need to see what the data shows. Mechanistically, what could be driving this? Well, again, we don't really know. Could this be an increase in plasma viscosity factor? Could this be microvascular dysfunction? I don't know. Many factors have been put forward, but I think this is a field where there are ongoing studies. What should be the blood pressure limit to be maintained in diabetic nephropathy? Well, really, I think the optimum here is to get to a systolic blood pressure of probably less than 130, and the guidelines would certainly advocate a systolic blood pressure less than 130. Many of the hypertension doctors would want to go for blood pressures of less than 120, and I certainly think that the lower is better when it comes to systolic blood pressure and nephropathy outcomes. If nephropathic patients have hypertriglyceridemia, can we give fibrates? Well, yes, we can, but you might also want to think of the other causes of hypertriglyceridemia, such as poor glucose control or potentially alcohol intake. What is the role of acetylcysteine and pyridoxamine in preventing and treating, and how many days should it be given? The answer to that question, I don't know. So I'll have to come back to you. What is the ascending order of developing micro-complication? Well, there doesn't really appear to be an ascending order of micro-complication. It's very variable. Undoubtedly, retinopathy is a very good marker of increased microvascular complication risk. So if there is evidence of retinopathy, we should always be looking for other microvascular complications. Low levels of lipid associated with suicidal tendency, that was just a coincidence that came out of the 4S study. Safe hypolipidemic, safe lipid-lowering drug in pregnancy. Basically, if pregnancy occurs, stop all lipid-lowering therapies. Which type of gliptins are better? Well, I think this is a very interesting question. There are no real head-to-head studies, Meta-analysis of the clinical trials has suggested that vildagliptin may have a slight efficacy advantage. There's certainly a price advantage for vildagliptin in people with renal impairment, as you're only using 50 milligrams once a day, which obviously comes with a price benefit. Does taurine I don't think there's any evidence of taurine being particularly nephroprotective in diabetics. What's your opinion on the role of clindipins and nephropathy? Well, I think there's again no evidence for these agents in diabetic nephropathy. How often should a patient be screened for nephropathy? Well, I think this is dependent on the baseline status. Our approach here really would be to do 6 monthly albuminuria and renal profiles in those without established nephropathy. And I think that's a very reasonable approach. In those with CKD, particularly CKD3B or CKD4, then more frequent 3 to 4 monthly renal profiles. And in those with CKD4 to 5, then there should be more close renal function monitoring. Treatment of choice in patients on maintenance dialysis, end-stage renal disease, I think insulin or a DPP-4 inhibitor in terms of managing glucose control. Teneligliptin over other DPP-4 inhibitors, I don't think there's any advantage whatsoever. Teneligliptin, in fact, has very little data associated with it in terms of risk-benefit profile, safety, pharmacology, etc. So I don't really see teneligliptin having any advantage, and in fact has very little evidence associated or data associated with it from a pharmacological or therapeutic perspective. How to treat diabetic gastroparesis? It's often very difficult. Currently, we would look to use agents such as antiemetics. Erythromycin can often be used to improve gastric emptying, and also advise patients to eat small meals more frequently is the approach. Another treatment that can be used with varying success, of course, is a gastric pacemaker. Which drug can use for postural hypotension, diabetic autonomic neuropathy? I think if postural hypotension occurs, you need to look at what the other concomitant medications are and manage those. So reduce the dose of ACE inhibitor, reduce the dose of diuretic, reduce the dose of calcium channel blocker. But also, if patients aren't on any of these and they're having significant postural hypotension, then a small dose of fludrocortisone can be quite useful, which is what I've just answered there. So yeah, small dose of fludrocortisone, 50 micrograms, for example, once a day, can be quite useful. Yes, you can use pioglitazone in coronary artery disease patients. The threshold to start fibrates in hypertriglyceridemia, I don't really think that there is any threshold per se. I said the benefit we're seeing in those with the low HDL cholesterol, men in particular, and the management of fibrates are of use potentially in people with retinopathy. Bearing in mind the combination lipid lowering therapy, fibrates and statins, increases the risk of myopathy. I mean, I think it's really LDL cholesterol that we should be treating. The question is which cholesterol particles should be treated first, LDL, VLDL. Interestingly, part of the mechanism of action that may be a benefit, that may be driving the outcome benefit seen with liraglutide, may be a reduction in triglyceride-containing VLDL particles in postprandial hyperlipidemia. best or maximum starting dose of metformin in a patient with type 2 diabetes and central obesity? Well, the starting dose is usually 500 milligrams twice daily, titrated up to 1 gram twice daily over a period of about a month or so. If GI side effects occur, then we'd start with 500 milligrams once a day and titrate up to 500 milligrams twice daily to try to minimize the GI side effects. Thiazides and hypoglycemia, why are they still prescribed in diabetes? Yeah, I mean, thiazides at higher doses have well been described as being associated with hyperglycemia and a deterioration of metabolic control, but at small dose, say bendrafluomethazide at 2.5 milligrams once a day, the impact that these drugs have on glucose control is fairly minimal. Is there any evidence of prescribing aspirin above 60? I think this is based on the coexisting cardiovascular risk of that patient. If you're 60 years of age, newly diagnosed, type 2 diabetes, no other cardiovascular risk, then age per se should not be a determinant of statin prescription. Efficacious drug in erectile dysfunction. The approach to erectile dysfunction would be the use of things like sildenafil, for example, but other agents can exacerbate erectile dysfunction. So just remember, statins and ACE inhibitors, as well as beta blockers and poor glucose control, are also determinants of erectile dysfunction. And also just bear in mind that psychological factors can be quite important when it comes to erectile dysfunction, not just physical factors. Any role of is there any role of N-acetylcysteine in slowing down progression? Not particularly. The best way to approach the management of diabetic nephropathy is optimal blood pressure and glucose control. Is the evidence of pioglitazone for causing bladder cancer? There was some initial epidemiology a few years ago suggesting that those people exposed to the highest dose of pioglitazone for the longest period of time were associated with an increase in bladder cancer. And there were also some mouse models, again, which is why we tend not to go with a 45 milligram dose for long periods of time. But hence the 15 to 30 milligram being the optimal desired dose of pioglitazone. Can we assess risk and manage well before? Can we assess risk and manage well before by doing HLA typing to high-risk patients? So I think this question is really getting at whether or not genotyping people, and I think the argument that I think it's philosophically a very good idea, but I just don't think there's sufficient evidence yet in diabetes, at least, that HLA typing is a way of identifying subgroups at higher risk, certainly of complications. Comment about therapy directed towards beta cells. So I've got a question, comment on therapy directed towards beta cells. Well, beta cell preservation has really never been demonstrated with any particular therapy in the human model setting. The optimum approach really to beta cell preservation currently is around reducing glucose and lipotoxicity. There doesn't appear to be anything that has been demonstrated, as I said, in man models of preservation of beta cell function. Where are we next? Metformin and renal function. So basically, the current situation within the NICE guidelines in the UK and the global approach is that if the GFR is below 45, then we, below 30, then we would discontinue metformin. Metformin-induced lactic acidosis with normal renal and cardiac status. Well, metformin can induce a metabolic acidosis in such a situation. It's very rare. However, metformin's induction of metabolic acidosis occurs in the context of intercurrent hypoxia at tissue level, where there may be a transient reduction in metformin clearance. So that's why that may occur, particularly if somebody develops, say, pneumonia, heart failure. That is a potential issue. So what is the best or maximum starting dose of metformin in central obesity? Well, as I said, 500 milligrams once a day or twice a day, escalating to 2 grams a day. Which OHA is most hepatotoxic? I don't think any OHA is more hepatotoxic than any other. Which OHA is best suitable for the liver disease patient? Well, as I said, if somebody has hepatic failure, then insulin is really the best approach. If you have serum, all drugs, OHAs, are actually not recommended if serum transaminase levels are 2.5 times the upper limit of baseline, largely because these agents aren't studied. However, liraglutide has been shown to be safe across all Childs-Pugh classifications of hepatic dysfunction, and we've got also data that the SGLT2 inhibitors are fairly safe in patients with hepatic dysfunction. But it's worthwhile mentioning that OHAs are not recommended based on a AST or serum transaminase levels 2.5 times the upper limit of normal. So is rosuvastatin safe in nephropathy? I think the answer to that is yes. Percentage incidence of diabetic gastropathy? Well, this really depends on the degree of metabolic control, duration of diabetes, as well as the presence of other comorbidities. And one should always think about potential of gastropathy, particularly if people are having a lot of glucose variability or hypoglycemia, when other causes of that have been addressed, as glucose variability may be associated, may be a consequence of defective nutrient absorption. So is aspirin or clopidogrel safer? So I mean, I think basically lower the dose, the better with respect to GI disturbance. So the dose here would be 75 milligrams. I think 150 milligrams is associated more in the way of GI upset and GI bleeding. Sodium bicarbonate supplementation, diabetic neuropathy. Really, sodium bicarbonate supplementation is something that will be done in the context of end-stage renal failure or advanced nephropathy, where there is a metabolic acidosis secondary to renal failure. And sodium bicarbonate in that situation can be quite useful to minimize the hyperkalemia. Right, so this other question here is about 800 kilocalorie a day restriction, and can it be a mainstream treatment plan? I think a calorie restriction diet can be very useful in inducing weight loss, certainly if people are being prepared for bariatric surgery. Can it be a mainstream treatment plan? I think it's very difficult to maintain 800 kilocalories a day. Having been to India many times, I would think it'd be quite difficult to eat only 800 kilocalories a day and make it sustainable. Is initial therapy with insulin preferred to OHA in a newly diagnosed type 2 diabetes patient? Well, I think the answer here is that the optimum approach is really to treat early and to intervene early. I don't think there's any evidence that insulin is better than OHAs. And I think what we are going to do is really aim for optimizing glucose control and try to limit clinical inertia. This is probably the best way. It's not so much how you do it in the early stages, but ensuring that we get in early. We've got a question here, is can diabetes be cured? Good question. Can it be cured? We can certainly go into remission. And weight loss and a significant weight loss is a very good approach to inducing diabetes remission. And we've seen lots of data that calorie restriction and a significant amount of weight loss is a very useful approach to inducing diabetes remission. As can, of course, bariatric surgery has been shown to do the same sort of thing. So I think that is the end of the questions. And I think with that, we have been going for quite some time now. We're over an hour and a half. So I think at this time, I think one last question I'll answer, and this is treatment of metformin-induced lactic acidosis. Well, the approach here would be supportive care, stop the metformin during the period of lactic acidosis, and whether or not there is an obvious precipitating factor is obviously important. If there is a precipitating factor, which there usually is, manage that. It isn't always the case that the metformin cannot be reintroduced, particularly if there has been a precipitating short-term factor like a pneumonia or an episode of flu or something like that. Okay, so I think the time is up. It's been my great pleasure to be part of this particular webcast. We've had a lot of questions. I've tried to answer as many as possible. I do hope you've enjoyed the session, and it has been my great pleasure to be here with you. So thank you all very much for your attention, and enjoy the rest of your evening. Thank you very much indeed, and goodbye for now. And I look forward to seeing you again in India soon, shortly. Thank you very much.